This is Scott Becker with Becker's Healthcare. Thrilled today to have a webinar on a key issue for health systems and practices and providers, solving for price transparency while improving the patient experience. We've got three magnificent panelists today. We have Emily Jones from Ensemble, Lena Tisden from Ensemble, and Stephen Forney, the CFO of Covenant Health. A great presentation. We'll begin today's presentation, and we'll have time at the end of the hour for question and answer session. You can submit your questions online through the webinar portal through typing them in. We look forward to hearing your questions. The session today is being recorded and will be available after the event. You can use the same link that you used to sign in today to hear the webinar afterwards. If others want to hear it, let us know. It's our pleasure to start today's webinar by introducing our presenters. Lena Tisden serves as the Senior Executive Revenue Integrity and CDM, overseeing all ChargeMaster services for Ensemble Health Partners. She began her career in healthcare 18 years ago, holding positions in every major area of the revenue cycle, and during that time led the development and implementation of a successful upfront patient collections project. Her comprehensive experience in revenue cycle and deep passion for customer service led to her being selected by leadership to train existing and new employees on successful business customer service principles and methodologies. After serving organizations and patients on the acute care side for over a decade, Lena was afforded the opportunity to lead and grow a team on the professional billing side. After relocating to Texas, Lena Tisden co-led a large hospital system conversion to ICD-10 and the implementation of a new ERP software product. Her vast knowledge in ChargeMaster and Charge Capture led her to initialize her skills and utilize her skills to improve operations, clinical areas, regional CFOs to optimize changing workflows and maximize reimbursement. She's had a remarkable career in revenue cycle. Emily Jones, who's our lead presenter today, together with Lena and Stephen, brings 17 years herself of revenue cycle experience to Ensemble. She's also had 5 years in the physician setting, supporting 20-plus practices, and 12 years in the acute care setting, so 17 years in total. She's managed patient access and pre-access functions for 14 years, including in her current role for multiple large health system clients. Prior to joining Ensemble, Emily served as a Senior Director of Pre-Arrival Services for the Shared Services Center at Fort Smith, which was a part of Community Health Systems, where she led the centralization efforts for pre-arrival and then ultimately serviced 30 hospitals in 5 states. During that time, her team implemented several best practice processes while doubling upfront collections and maintaining a front-end denial rate of less than 0.5%. During a pilot for a shared services management services team of 3 hospital on-site patient access, her teams were able to lower front-end rejections by 50% and implement automated processes that previously had relied heavily on paper and improve front-end accuracy scores by a great deal, by more than 13% in less than 3 months. She's got a magnificent career in revenue cycle. Prior to joining Community Health Systems and NHMA, she also had work in corporate pre-arrival director for oversight of 72 hospitals. She was a regional patient access director with oversight of 14 hospitals and patient access manager of a nearly 500-bed facility. Finally, our third presenter today is Stephen Forney. Stephen serves as the Chief Financial Officer for Covenant Health, a magnificent health system. In this capacity, he oversees strategic, fiduciary, and operating responsibilities, including accounting, treasury, planning, budgeting, and financial reporting. He also provides daily financial leadership and oversight to achieve financial performance. Stephen brings to his role 30-plus years of experience in healthcare finance and operations in acute and post-acute physician practice and other settings. He's got a great focus on operational improvements. Before coming to Covenant Health, he served in numerous different leadership capacities, He serves as CFO of the Chinese Hospital Association in San Francisco, as CFO for System Operations for Prospective Medical Holdings in Los Angeles, and also as CEO for Verity Health System in Redwood Shores. He's also been a Vice President and CFO for Ardent Health Services and Globalist Health System, very successful systems. At this point, I'm going to turn it over for the core of the presentation to Emily, and she'll get us started. We'll have time at the end for question and answer. Thank you to Emily, Lena, and Stephen for the presentation today. Emily, let me turn it over to you.
Great. Thank you so much for that. As we're flipping through the slides here, I will remind the group to feel free and go ahead and enter your question here. I will address the questions at the end, but certainly as we come across items, feel free to go ahead and get that question in so you don't have to write it down, and remember that towards the end of the presentation. This is just a quick disclaimer that while we certainly want to provide the most accurate and up-to-date information around price transparency and how hospitals and organizations are choosing to solve for that, we certainly recommend that you work with your local compliance, revenue cycle leadership, CFO, managed care teams to ensure that you really have the best plan for you and your organization. Some states may even have their own specific requirements around price transparency. So we want to share with you today how some best practices and what we've seen organizations handle with solving for price transparency, but as always, make sure that you have a plan that will work best for you. So for today's agenda, we're going to do a brief overview of the current price transparency requirements. We'll point out a few things that you may have missed or that we have noticed several organizations maybe are underestimating or have just quickly glanced through in the overall requirements that we really would like to point out. We'll share some examples of how organizations are solving for price transparency, and especially in a way that improves the overall patient experience. And certainly, Stephen's going to share along with us throughout the journey, really from a CFO's perspective, how are CFOs thinking about price transparency? How are they planning to solve for this? What are some strategic ways to look at this, especially when thinking about posting your negotiated rates online? And he'll bring that insight and wisdom to this discussion. And then lastly, we'll have our overall Q&A. This is here just a brief timeline of what has happened with price transparency. This has been a hot topic for at least a few years off and on, and certainly much more so in the past 12 plus months. Quite a bit of activity has happened before November, but this was when CMS published their overall proposed rule for 2021 price transparency. CMS actually held in December, so in the middle here, a clarification webinar in the proposed rule versus the finalized rule and some additional information, which if you haven't listened to that or read the transcript, it's out there on the CMS website. It actually was a helpful resource for us as we attended that and looked at some of their additional guidance, so it's a good resource for you as well. In May of this year, Medicare published the IPPS proposed rule. In June, we've had activity with courts upholding the overall price transparency requirement that was published a few months earlier. Certainly, there have been petitions and lobbying and additional activity that's happened from hospital associations and various hospital groups. However, so far, there has been no change of course in the requirement to meet price transparency for January of 2021. So whether or not there may be a change at the last minute or a modification in the rule, we certainly recommend that organizations prepare today as if this rule will be in full effect for January of 2021. As we think about the overall price transparency requirements, there are two main components that really come to mind in what is required for publication or accessibility from the patient's perspective or user's perspective. One is an overall machine readable file for standard charges of items and services. And here are 5 specific items that fall under this machine readable file where individuals could access gross charges, discounted cash prices, payer-specific negotiated charges, and then de-identified minimum and maximum negotiated charges. The second component is the requirement to post 300 shoppable services. Shoppable services essentially being defined as services that could be scheduled in advance. CMS has defined 70 specific services that should be included here, and has allowed the facility or organization to determine an additional 230 shoppable services that may be included as its overall 300. Additional components of that should be included are discounted cash prices, again, payer-specific charges, and then the de-identified minimum and maximum. CMS did clarify in their webinar back in December that an estimator tool can be used in place of the shoppable services component, and we'll talk about that in a little bit further here. I did want to show a comparison of what's required or what specifically is needed for the machine readable file versus the shoppable services. This tends to create quite a bit of confusion for organizations and understanding, you know, which component does the estimator replace? Is it both of them? Is it part of them? Where do we have to post a file versus not? So a couple of key things we wanted to point out here is that in the description of item or service and billing codes, the machine readable file really is just calling for an overall description, whereas the shoppable services calls for a plain language description of each of these shoppable services in addition to those other items listed. There is no requirement for facilities to indicate that a certain charge item or line item is not offered by the facility unless it is one of the CMS 70 defined shoppable services. Then there is a requirement for facilities to indicate they do not offer one or more of those services. From a formatting and naming convention on the machine readable file, there is a dedicated or designated format and naming convention that should be used. However, for shoppable services, there is no defined requirement. And then for the remainder of these items, for the most part, they align in what's required. There are some minor differences in the search capability of the machine readable file versus shoppable services, but the remainder of those, for the most part, are similar. Stephen, from an overall CFO's perspective, when you or other CFOs have thought about posting negotiated rates or other prices online, what are maybe a few of the top concerns that you've had or that others have had that they've shared with you?
Well, there's a number of different items that could potentially be concerning or problematic related to doing this. It's going to be putting a lot of information out in the public domain that has not historically been public. So you're going to have not just consumers that will have interest in it, employers will have interest, other health plans will have interest, competitors will have interest. And this will open up a number of different dynamics potentially across the healthcare industry, that many of which would be speculative at this point, but to touch on a few, I would expect that most CFOs are going to most employers are going to start being approached by consultants that will use this information to say, hospital X is cheaper than hospital Y. You should try to direct your business to hospital X. I expect that health plans will try to use this information in negotiations. I expect the consumers are going to be potentially very confused about a lot of it because the comprehensive machine readable file will be very comprehensive but dense, to say the least, and without specific industry knowledge, it'd be very difficult to use for any sort of meaningful consumer basis to things, whereas the consumer-friendly display of shoppable services is much more straight, normal language formatted. However, if an organization is only posting 300 shoppable services, that's not particularly complete, and it leaves a lot of opportunity for consumers to not really get a good experience out of it. If they're using a comprehensive tool, that obviously helps, but there's still going to be a significant learning curve, a significant amount of time and effort that an organization would then have to put into helping the consumer work through that information. Now, of course, some of this goes the other way too. It will allow organizations to understand, sort of where they sit in a market relative to rates. It'll allow the ability to go directly to employers and say, hey, we are positioned in this way in the market, so this is why you should use us. So there's a lot of potential ups and downs that go with this, but as I mentioned before, it'll be a very interesting dynamic now that this information has been put into the public market, and there'll be a lot of work for a lot of consultants that right now don't have anything to do.
Yeah, I think those are absolutely great points, and I agree that I think the machine-readable file will become very cumbersome and confusing for patients. And even on, the display of the shoppable services, although if you're simply posting the overall rates, a patient's individual benefits may differ amongst many plans, and different deductibles and out-of-pocket maxes that may be met, it still can cause a lot of confusion or frustration on behalf of the overall patient. We did include in here, and again, this is available on CMS, just an overall estimator tool checklist that can help organizations confirm whether or not a public or patient-facing estimator tool is sufficient to meet the CMS requirement for the 300 shoppable services. There's some more detailed information available on the website, but this is the overall quick reference checklist to ensure that it's sufficient. A couple of things to call out really around accessibility is the tool should not require a patient or a person to sign up and register an account. However, in the CMS clarification webinar, they did reference that you can require a patient to enter their specific insurance information in order to pull back that out-of-pocket amount or that benefit information for those specific services. And as we think about creating the most accurate estimate for a patient, that may actually be more helpful for them to have that feedback from their payer and to have those out-of-pocket amounts calculated for them so they can have the most up-to-date information as possible. Over the next couple of slides, we'll walk through 6 key items that you may have missed or that you may have overlooked in some of the overall requirements for price transparency. The first one being that in the overall items and services and the estimated patient due amounts or allowables, that these amounts should also include any employed provider items and services or estimates that would be billed from the facility perspective. So, for example, as a facility or organization, if you employ the cardiac surgeon who is going to be performing a cath lab procedure at a facility, then your patient estimate that patient is attempting to calculate or look through the shoppable services component should include not only the amount and ancillary services that are due from the facility billing perspective, but also from that employed provider perspective. This could also be especially challenging for organizations where your acute billing services are completed out of one host system while your provider services are billed out of a separate host system. So certainly want to make sure that that is called out for you. From our perspective, we work with a variety of different estimate vendors, and we've asked them to start producing some sample letters of what the estimates will look like. From a patient experience perspective, we certainly want it called out to say, here's the estimated amount due from the facility, and then here's the component that may be billed to you from a provider aspect. So that would be something I highly would recommend that you evaluate. And also, if you're utilizing an estimate vendor or if your host system is going to be utilized for patient-facing estimates, that you clearly call out the difference between those in a patient-friendly way. The second item here that you may have missed or overlooked is that the standard machine readable file requirement does include payer negotiated rates. Various organizations that we've talked with have attempted to state they'll use gross charges or they'll use the de-identified charges, but from a standard charges perspective, as we look at the CMS requirements for the machine readable file, it does include those payer negotiated rates. And then the third item here is that if you offer a price estimator tool to satisfy a portion of the price transparency component for the shoppable services, it can satisfy that requirement, but it does not alleviate the requirement to post the standard charges machine readable file requirement. CMS also has encouraged organizations, although this is not required, so this is more of a potential nice thing for our patients, is that organizations offer this type of education or visibility to the patient. So alerting them of the availability of financial aid or assistance, any payment plans or discounts that may be offered, and certainly assistance with enrolling them in Medicaid, state, or maybe even a charity care program. An indicator for the quality of care in the overall healthcare setting, and making the standard charge information available in languages other than English, especially if you're in a community that has another Spanish is a high population, or Vietnamese or other languages that are out there based on the needs of your community, that you offer that as an option. Contracts with non-payer companies may need to be included. And the example used here by CMS was the employer essentially down the street where you have a negotiated rate with them to do potentially drug screens or health checks or other services for their employees or for folks that they refer to your organization. So as you evaluate those negotiated rates and posting those amounts, in order to be compliant, don't forget about any of these types of contracts that you may have that are not traditional insurance payer type contracts or agreements. And then lastly, this was a hot topic that came up in the proposed webinar, and then certainly some comments to CMS on that thereafter, is what does an organization do if they have a contract with a payer that prohibits them from posting those contracted or allowable rates? And essentially the feedback from CMS, and this is also posted in the frequently asked questions section, is that organizations should work with payers to adjust or make an addendum to that overall verbiage, or to confirm whether or not a federal requirement would supersede the limitation of posting those overall rates from a payer contract perspective. Stephen, from a CFO's perspective, any thoughts on how we could urge payers to change this language, or anything that you may have heard from payers where this is a concern or pain point for them in modifying that?
You know, nothing in particular from a specific payer, at least not here. But, you know, my general perspective on this is, you know, if you think through the boilerplate in most managed care agreements, there's always language around federal and state law, changes in federal and state law superseding specific clauses of the agreement, and that virtually all the clauses are severable from one another. So, you know, it's certainly not too far a stretch to say that a CMS requirement that this information be posted publicly would fall into that category and wouldn't necessarily void your contract, but would create an environment where everybody would have to adjust to this. Now, it certainly is appropriate and, you know, desired to work specifically with payers to actually paper this directly and say, in something along the line that in recognition of new CMS requirements, we agree and we acknowledge that this information will be posted in a public fashion, et cetera, et cetera. And so that's not a short and quick process. And so it would be something that, given that January 1 is rapidly approaching, that those discussions should be being had in a fairly aggressive fashion with payers to make sure that they're not caught off guard. One thing, to keep in mind that just because something is very much at the forefront of the hospital industry, perspective and understanding that, hey, we've got to get this done, that doesn't necessarily mean it's at the forefront of the health plan industry. This may, to a given health plan, it's because it's not their compliance requirement, so it may very well be something that is very much on their back burner for them, and they may not be thinking of it. And so the last thing you want to do is surprise one of your payers by doing this and having them not have heard it from you first. So it's really important, obviously, that we get out in front of this and be working with our payers towards at least making sure everybody's notified, if not having amendments in place come January 1.
Great point. Thank you. All right. I am going to turn over the next few slides here over to Lena to talk about some considerations for the overall shoppable services. Lena?
Great. Thank you, Emily. Such a pleasure to be here today with all of you talking about price transparency, I think our favorite topic of the year maybe. So I'm going to start just by talking through some of the data elements and format for those 300 shoppable services. I'll talk about the plan if you're posting that manually on your website versus having that online patient estimate tool option that Emily discussed, which does provide, a relief if you, per se from having to go through the process of manually creating that 300 shoppable services file, which does have some additional requirements with it. So first and foremost, the rule behind those 300 shoppable services, as Emily mentioned, CMS did provide 70 mandated shoppable services. You probably noticed that there were some DRGs that were kind of penciled in there as well, but allowed the opportunity at this point for hospitals to select additional services that they deem are commonly provided to their patients. And I'll be discussing in just a few minutes kind of the strategy for supplementing those common services to create that full list of 300. Just a couple of exceptions to point out that if a hospital does not provide one of the 70 CMS services, you're able to select at free will additional services that you would like to post. So, for example, in one of the 70, if you don't provide 5 of those, then whatever methodology you use to come up with the additional 200 and some odd services, you have full discretion to select whatever additional services that you'd like. So if you're really doing a lot of patient services in your lab department or your diagnostic services, you can choose to backfill those 5 that you don't provide out of that CMS listing with services of your choosing. If you're thinking, my hospital or one of my facilities, I don't think we have 300 services that we can post. CMS did state just to post as many as you're able, that you don't have to post equal to 300 services. So if you only provide 200 services, to post those 200. I wanted to provide a little bit of guidance around selection strategy for those 300 shoppable services. Just some kind of things to not forget, to make sure that you're thinking about as you go through that selection process. And then on the next slide, I'll give some kind of my personal quick tips on what's worked well for us helping with those proposals for our clients. So first and foremost, running utilization based on CPT or HCPCS codes to look at what the highest utilization of services have been over the course of time. We know that we had COVID this year and that we had a really high utilization of those services, but, running utilizations from the beginning of the year, for a 6-month period or an 8-month period will help give you a good start with selecting those initial services. Don't forget that if you have services that are soft-coded, we know that not all hospitals soft-code or hard-code the same procedure. So, where one hospital may hard-code a certain type of service, endoscopy services, another facility may choose to soft-code those. So, being able to either run a report through, a patient access tool to see what types of services are being scheduled by patients, being able to run some sort of a report out of 3M to identify those services that the coders are coding is a really helpful tip to make sure that you're including services that patients are coming in for that could be considered shoppable. We also look at creating kind of a shoppable services workbook that will eventually contain all of those 300 services that you'll be selecting. Again, don't forget to backfill services or really keep track of how many of those CMS 70 you don't perform to come up with that full 300 selection. One of the types of services that we've seen come up in that higher utilization are obviously emergency room levels. So don't forget to remove any services that don't meet that shoppable services definition. And also, with emergency room levels, those can't be scheduled in advance. So just remember to go back through and, looking at highest utilization and weed out those ones that wouldn't fall into that definition. If you have more than one facility that you're looking at or that you have to post your services for, we do recommend creating an initial standardized approach to selecting those services. So if you have 4 hospitals that you're looking at 300 shoppable services, and all of those hospitals perform the same 200 services, starting with standardizing those services across those 4 hospitals, and then looking individually where you can plug in additional services for each of those facilities, again, to reach that 300 facility threshold. We've taken a pretty strategic approach to the shoppable services selection. The utilization is obviously a great start, but looking at it from a few different angles. One is looking at your competitor pricing. So maybe you have some services that that you're priced lower than your competitors in the market, and maybe you don't have a high utilization. And normally, if you're just looking at the utilization, wouldn't fall into that top 300. If you know that you're priced lower than your peers, that would be a good kind of strategy to take with even your marketing department to say, okay, in 2021, we really want to hit these specific services hard. We know that we are priced lower than our competitors, and we really want to try to get as much of that business as possible. And then targeting specific services, like I said. So if you do a lot of diagnostic services, a lot of lab services, some specialty type services, making sure that patients are able to shop for those is a really good, just a couple of really good strategic approaches that we've seen some success taking. So, Stephen, I do want to ask you kind of what your thoughts are on taking more strategic approach to the shoppable services with price transparency and some of those considerations.
Yes, I think there's certainly an opportunity with this sort of transparency to understand in a much more straightforward sense how you align with your competitors in a given community. Now that, obviously gives you an opportunity to adjust pricing. It gives you an opportunity to make sure that you are posting pricing, posting services similar to the services they're posting so that can be well identified by the consumer. It also gives you an opportunity to highlight other differences. One of the suggested comments by suggested ads by CMS was quality indicators. So there's going to be certain circumstances where you are going to have competitors in your marketplace that, for one reason or another, are simply going to have lower negotiated rates. The example might be, a large tertiary facility versus a smaller community hospital. One of the things that is useful in that type of environment, obviously if it's true, is to focus on price doesn't necessarily equal value of care. And being able to add a quality dimension to the pricing dimension would be a way to differentiate that, well, we may be more expensive, but we provide, our quality metrics are higher in whatever way that could be presented. So that's a message that is going to be potentially valuable depending on the circumstances of the market. From another, point on strategy around this is this additional transparency gives an organization opportunities to better align with their patients. This, by really embracing this and, looking at transparency as a strategic tool, that allows an organization to really partner with patients to control the cost of their healthcare. And to the extent that an organization is successful in making the patient feel like they are a partner in helping them manage costs, that it then becomes a competitive advantage in a market.
Thank you, Stephen. Yeah, really appreciate your thoughts on the quality piece. I think you had that spot on. Thank you. Most of you may have seen this example that CMS published. They provided a colonoscopy as an example. Again, this is specifically related to if you're posting the 300 shoppable services on your website, not utilizing the online patient estimate tool. But you can see here on the screen that this lists your primary procedure, any anesthesia that's provided, the physician component, pathology, and then the facility fee. Something that I want to make sure that everyone has a chance to go out and read is the update for IPPS for 2021. And there is specific language in the IPPS that points to the Medicare cost report that falls under that price transparency umbrella. So we are the requirement to include on the Medicare cost report that median payer-specific negotiated charge that may have been negotiated with Medicare Advantage organizations, and then the payer-specific negotiated charges used by the hospitals to calculate these medians. Again, please take time to go out and read through this. The hospital requirement, again, is to include on the Medicare cost report that information, beginning with the cost report periods that are ending on or after January 1st of 2021. There is a potential monetary penalty for noncompliance related to not receiving Medicare payments. So again, just something really important that we wanted to point out. So take some time to go through and read through those. People
Emily,
often ask about, go ahead, Emily.
No worries. I did just want to point out, it looked like the articles weren't coming through very clearly on the previous slide, but there are a few articles that have been posted recently, and certainly we can share that with the group afterwards, on some considerations for organizations that are stating they would rather take the penalty for price transparency rather than participate. So certainly there's the monetary penalty of up to $300 per day per facility. There is the consideration that on the Hospital Compare website for CMS that your organization would not indicate that they're price transparency compliant, and then with the IPPS updates, There are some opinions out there that you may be subject to potentially losing Medicare payments if you do not comply with at least the IPPS requirements. So as you're thinking about whether or not as an organization to comply or to take the penalty, those are just some additional considerations for you to review in making those decisions.
And just to add to that, Emily, CMS is not an organization that is particularly known for stopping at a particular penalty. Once you get called out for something, they tend to look for other things, and so this seems like a not the way that you want to get on the website for doing something wrong.
Yes, that is a great point. I'm sure that they'll use that opportunity to do a deeper dive in several other areas as well. All right, so as we talk about some solutions and ways that people are solving for price transparency, certainly we recognize that solving for price transparency unfortunately can't rest on the shoulders of any individual department or person. And so as you're considering how you solve for price transparency, or if maybe you haven't been involved in some of these discussions, we really recommend that you form, whether you want to call it an internal governance or subcommittee or work group, but really a multidisciplinary approach to how you will meet the individual requirements or whether or not you choose to solve for some of these items. The key stakeholders that we highly recommend are your patient access leader, CFO, contract management, compliance, a back-end revenue cycle leader or representative, and then certainly coordination with managed care. While you may want to designate or should designate a price transparency owner or champion, we really believe that input is needed from each of these areas to holistically solve for price transparency, but then to also come up with solutions that are going to be patient-focused and patient-friendly, and to help provide education for what options are available for your facility or organization, and how we're really enhancing that patient experience overall. Through that work group, or as you look at how you may choose to solve for price transparency, one of the first places that we would recommend that you start is by evaluating your tools and technology and what you have to work with today. So for some of you, you may have really robust tools or bolt-on systems, or your host system may provide this information, or you may have a closed vendor relationship where this is a no-brainer and it's simplistic for you to roll this out. But for many organizations that we interact with or that we work with, this is really a challenge where system optimization is needed, additional vendor engagement is needed, those types of things. But first, we need to understand where we are today. How will you generate estimates? Can patients generate their own estimate in a way that's compliant with CMS for the shoppable services piece? How you provide the information on a public website, as close to front page as possible with as few minimal clicks to accessing that information. And how will you then interact with the patient? So do you have the capability to email back and forth with patients with questions, chat, text, post tutorials or walkthrough guides? What current technology and tools do you have available? As we look at solving for price transparency in a way that is really patient-focused or really through the lens of patient experience, we tend to think about these things through a people, process, and technology perspective. So from an overall people perspective, this is really ensuring that your associates and your organization understand how we will not only meet the minimum requirements of price transparency, but how can we use this to really enhance the overall patient experience. So possibly instead of referring them to a website or a very large Excel file or pointing them in one direction, we may want to offer self-service tools, but we also want to guide the patient through the process. So you may consider doing things like educating patients on how insurance works, right? So you may want to post tutorial videos or small 1 to 2 minute videos or voiceovers or a quick PDF or tip sheet or infographic that really explains to patients, you know, hey, I have insurance, why do I owe anything? Well, here's how insurance works, and here's what a deductible is and a copay and coinsurance, and here's why you might owe a dollar amount. Here's a step-by-step guide on how to create an accurate estimate or how to apply for financial assistance. Maybe you want to place a quick little quiz or question and answers on your website to let patients know if they're even eligible for these types of things. But really evaluating not just, okay, we're going to meet the basics of price transparency, but from a people aspect, how do we become the place that patients go to even get their hands around how all of this works and what all of this means, so that they can make the best decision for them and for their friends or family. From a process aspect, there are, especially for our scheduled services, there are several different points of contact and opportunity to have conversations with patients. These certainly aren't the only points of contact, and that's why we feel strongly that you should have a robust team that's aware of price transparency and how the organization is solving for it. But some items, if you will really optimize how you're engaging with patients through scheduling and fully pre-registering the patient, creating an estimate, walking them through the estimate and financial counseling process even before their date of service, then you can certainly educate them, streamline the registration process, but then you can also more quickly identify a patient's propensity to pay. You can connect patients with financial assistance as needed, and you can even do things like, let's say, for example, a patient even is a walk-in patient or an ED patient, and they're unable to pay or they have questions. You might provide an appointment card, or you might schedule them time to come in and speak with a financial counselor. But there are many ways throughout the front-end process, especially, where you have the opportunity to engage with patients and have a conversation to help educate them on the process and really help, from a concierge perspective, help them navigate all of those components. From a technology aspect, there will be some patients that want to have as many self-service capabilities as possible. So they may want to schedule their own tests, they may want to create their own estimate, do their own price shopping. They may want to do this at midnight, 3 a.m., anytime. They really want to be self-service driven. So certainly we recommend where you're able to provide a self-service capability that you do provide that. However, we'd also recommend that you look at fast options that you can connect patients where they may get stuck in the process or they may have questions. And if you have the technology or you want to invest in that technology, it may be a capability to do texting with patients, chat, email, phone, or even in-person assistance. But we do recommend, whether a patient is calling in to price shop or has questions throughout the process, or they're navigating the self-service piece, that you can quickly refer them to additional help as needed, because you don't want them to become frustrated in the process and abandon what they're doing in an attempt to come to the organization. The last item here is any additional language or communication considerations should be taken into account for patients that may not primarily speak English or the language in your area, or at least point them to a resource that they can utilize. If you don't have really robust technology and you're thinking about some additional options for interacting with patients outside of the normal business hours, you might even work with IT to develop a HIPAA-compliant web submission form on your website. You could also have a dedicated email group where that form would be submitted or where a patient may email a question and receive a response within 24 hours. Those are things that are very cost effective and typically easy for facilities to implement that can give patients an option outside of your traditional business hours to ask questions or get responses to, and allow you to implement that fairly quickly. Lastly, we just want to share some resources on the CMS website. You'll see the web address here. They do have a frequently asked questions document, a few readiness checklists, and some step-by-step recommendations for meeting both the machine-readable file and the consumer-friendly display options on CMS. But thank you all. I know we have some questions here in the queue, and we're happy to answer all those that we can get to today, but certainly want to thank you all for attending and engaging through the questions.
Great. Emily, Lena, Stephen, great presentation. We've got a number of questions. Let me get right to those. And Emily and Lena, or you'll tell me who the right person is to answer this. What facilities are considered hospitals for purposes of this rule?
So Emily, I can take this one.
Yeah, great.
So CMS defined a hospital, and you know, as she just stated, we did provide those resources. The CMS recent FAQs goes back through and defines all of this. But it is defined as an institution in any state in which state or applicable local law provides for the licensing of hospitals that is licensed as a hospital or is approved by the agency of such state or locality responsible for licensing hospitals. Exceptions to these reporting requirements are your federally owned or operated institutions, your ASCs, and non-hospital sites of care, so labs and imaging centers. So again, I think going to that CMS, the cms.gov, and looking at the FAQs, they do a really good job of defining hospitals and items and services as well.
Thank you. Another question. What, you know, our organization, the question is, our organization's not really started on this. What should we do? How do we get going? I mean, that's really the next question. Emily or Lena, do you want to take a shot at that? Stephen, I think you've already gotten out in front of this. So let me ask one of the leaders from the Rev Cycle organization to tell us.
Yeah, sure.
Emily?
So, yes, I'll be happy to answer that one. I think if my organization had not already started working on this, or I wasn't even quite sure where we were, I would start by coordinating with the CFO or main administrative revenue cycle leader and talking through the overall requirements and standing up that governance committee or work group to collectively work together as a team on how we will solve for some of these things. There are also those nice checklists available on CMS that you may just take some time and go through those checklists and identify specifically the areas that have the greatest concern that you feel we're significantly behind on, and develop a plan for how quickly you can get those items implemented.
Thank you. Stephen, let me ask you this question. Will this be dynamic? Will people be regularly updating this transparency and this ChargeMaster data, or will it be done once a year? Any sense of how you'll look at that?
Well, it's going to depend on which an organization's internal processes look like. Many organizations do only update their charges once a year, with the exception of maybe they've added new services or added a new CPT code or something of that nature, in which case, you know, they might make minor modifications throughout the year, but the main update would be annual. There are other organizations that do multiple CDM updates throughout the year as a course of business, annually, quarterly, or by semi-annually or quarterly sometimes. There are also organizations that, you know, very complex, that might be very dynamic in how they're adding new services and discontinuing services throughout the year, in which case they would probably be updating that on a continual basis. So I would view that as being very organization specific, although probably, probably a majority of healthcare organizations would probably view this as an annual event.
Thank you. Another question. We had a question, Emily or Lena, about when rates are sort of situation-based, where a payer's given rates that can be for different situations. Any thoughts on how you'd sort of filter through that and make specific for price transparency purposes?
So one of
Lena, do you mind
in the
to talk through that one?
Yeah, absolutely. So with the machine-readable file, one of the clarifications or examples that hospitals were provided related to those service packages, and that's definitely been we've had a lot of questions about that with our clients, and the guidance has been, looking at those procedures. So we'll use the colonoscopy procedure as an example, and having that as one line in that machine-readable file, which would be considered a package service, including all of your anesthesia charges and your supply charges, and listing that on that singular line, and then incorporating in what that payer negotiated rate, or the payer negotiated rates, I should say, for those payers across the top on that machine-readable file. So really it is kind of a one-liner that would include, the gross charges for all of those components and then those individual payer rates.
Thank you very much. We've got one great comment from our audience saying that we've been working on this for 6+ months and still don't feel anywhere near ready for this, which I think is telling about where people are at on this in general. Emily, let me ask you this question. You'll let us know whether this is a Lena or Steve question. Are you seeing most hospitals use a tool for shoppable services or post the services online?
Yeah, so most of the organizations that we've engaged with or have had conversations with are looking for a tool. I will say some facilities are just starting to think about what this might look like, and so they may be in a little bit of crunch mode to implement something that can be patient-facing. And to be honest, some of the tools that are out there, they're also working tirelessly to make sure that their technology is enhanced in order to meet this requirement. So overall, I would say most are going to be utilizing a tool of some sort. However, for the person that felt like they're still not quite ready, I think overall in the industry that you're not alone. That's a feeling across several organizations and even some of our vendors that may provide that technology as well.
Another question, and you must still see some of this, each of you. A hospital doesn't have a contract management system, a core contract management system for their payer rates. How should they go about getting all the negotiated charges? How should they go about, sort of working through this data? Emily, any thoughts there?
Yeah, Lena, do you want to take that question?
Yep. I sure can. Yep, so I think that there are a couple of ways. One is utilizing, if you have a payer contract grid, that would help, itemize out what payers you have contracts with, what those negotiated contract rates look like. I know that that's a little bit more manual than maybe what you're looking for, but that is definitely an option. We also have people that are utilizing their 835 claims data. Even though it's not pulling directly from a contract management system, it is giving them some guidance on payer, what that allowed amount has been, and helping guide them in that direction as well. So just a couple of options if you don't have a current contract management system.
Thank you. We're right at 2 o'clock. Emily, Lena, Steve, I'd like to ask you one more question, and then I think we have to wrap up just in courtesy to our audience, but then we'll figure out a way to follow up with questions post webinar. The question that we've got from somebody is, our hospital doesn't have any shoppable services. Does our hospital still need to list a set of services? How do you go about this? How do you deal with this if you don't have quote-unquote shoppable services? Any thoughts on that, Emily, Lena, or Steve?
Yeah, so I can go first and let the other two chime in here. I think for the overall CMS, the top 70 shoppable services, you just still want to ensure that you're posting on the website that for each of those shoppable services, your hospital does not provide that, and that there are truly no services that would be potentially scheduled in advance. And if you look at even what CMS has on their listing, there are things that typically we may not see as scheduled, but certainly could be, such as outpatient labs or other E&M type services that are being completed within the facility setting. So I would just look very closely at that list, and also anything that could be done on a walk-in or scheduled basis, and include those, if you have those, as your shoppable services. Lena, anything you want to add there? Stephen?
Yeah, I would, in trying to think through the sorts of organizations that might not view themselves as having shoppable services, maybe large quaternary, not outpatient-facing organizations. I think there is still CMS would still view organizations like that as having quote-unquote shoppable services, because people can select to go there and people can schedule services, albeit, you get into various treatment regimens and it's sort of scheduled for you as opposed to you scheduling them. But I think that CMS would still view that as being shoppable per se.
Thank you. Ensemble Health, Covenant Health, I want to thank you as well as our audience, and of course, Emily Jones, Lena Tisden, Stephen Forney for joining us today. A really great presentation on a subject that is so near and dear to everybody's hearts and minds that's in revenue cycle today. And a lot of people, like the person who questioned this, who said, what if you haven't started yet? Or what if I've been at this for 6 months and we're still in bad shape? There are a lot of people in that position, and I know Ensemble Health Partners can help, and Covenant Health. Stephen, can't tell you how much we appreciate you joining as well today. Thank you very much for joining this webinar on solving for price transparency. Thank you very much.
Thank you.
Thank you.
Thank you.
This will thank you. This will conclude today's webinar. Thank you very much for joining this Becker's Healthcare webinar, brought to you with Ensemble Health Partners and Covenant Health. Thank you.